Thank you so much.
Thank you very much. Thank you very much. Yeah, so if you would write your questions on the card early on, I mean, we can take some later, but this way, we'll collect them about halfway through, and then Jim or somebody else can take a look at them and kind of collate them, because there'll probably be a lot of the same questions, and that way I can read them off, and it'll save a little time, walking around with microphones and things. And then if we got time at the end, we'll do that. And you can ask questions if you have questions, outside of the low vision realm or outside of what I'm talking about here. I'll answer them if I can. If I can, I won't give you any BS. I don't do that. I believe in truth in advertising. There is no fake news or fake data here. So here we go. I do quite a lot of lecturing, and my wife was listening to me once, and she said, your titles are boring. Why would anyone come and see you? Because it's like, how to do low vision. Nobody wants to do that. So we came up with, we started thinking about how we title these things. And, one thing that people ask me is, can't anything be done here? So the title of this is, Can Nothing Else Be Done? And that something else happens to be low vision. So we're going to talk about that. So who are these guys? How many people from Minnesota, upper Midwest here? Well, you probably know about Mayo Clinic, but these two guys are Will and Charlie Mayo. These are the Mayo brothers, and they and their father started a medical practice in Rochester, Minnesota in the 1880s. And without going into a great amount of detail, it's now developed into the premier medical care center in the world, basically. I mean, everybody knows who Mayo Clinic is. So these are my wife keeps saying that I work for two dead guys, because everybody goes back to these two characters here. But there's a whole book of sayings, aphorisms of these two guys, things they said. And the one that I picked out, because I use this a lot, the best interest of the patient is the only interest to be considered. Now, think about that. Here I am, I'm a low vision practitioner, and, God bless them. I have the best colleagues you could ever ask for. I've been at Mayo almost 20 years now. My colleagues are wonderful. They treat me professionally. I mean, the fact that I'm an optometrist, they don't care as long as I get the job done. But, I still don't see every patient. I still have patients come in and say, and I'll do the whole low vision thing, and they'll say, how come I didn't see you before? Well, if we were making a referral for something medical, for a retinal detachment or some other surgical procedure, bang, get it right away. But somehow the vision rehabilitation gets pushed to the side. So I put this up here because I think low vision is important, that every person with a vision impairment should be somewhere along the line have a conversation with a low vision specialist, not just somebody who kind of plays around with magnifiers. I'll be a little bit elitist here. What can I say? I'm a diplomate in the low vision section of the American Academy of Optometry. There are 100 of us, about 75 of us are clinicians around the world. So that's not to say there aren't a lot of other people out there that know a lot about low vision, but it goes to show you, we're the only certifying body for low vision. So, having someone to have a low vision patient see someone who really knows the ins and outs and approaches this from a rehabilitative standpoint, which is basically what I'm going to be talking about here. Low vision is not just a bunch of magnifiers, stronger glasses, yada, yada, which those are all tools that we use, but there's a lot more to it than that. So that's what we're going to be talking about today. So these are the main clinic buildings. It's the Mayo building on the right, the Gonda on the left, and I know this is a little hard for those of you with vision impairments to see, but these big diagrams, you are here. Yeah, well, we're in the corner on the 7th floor of the Mayo building. At least for now, that is probably changing, but so that's where we hang out. So what do we do? What's our goal in low vision? I often tell people right off the bat, I'm not the person who's going to transplant your eyeballs. I don't do a brain transplant, I don't do an eyeball transplant, I don't do an optic nerve transplant. I take what the patient has and try and get them to do the things that they want to be able to do. So what we're going to do is maximize the function of the individual based on the vision they have so that they can achieve their full potential, be independent, improve quality of life, do all that fun stuff. So that's really what we do here. Now, let's be a little bit more specific. We treat the vision loss associated with eye disease. When I lecture at big professional meetings, I might have 35, 50 people in a room. Down the hall, where they're talking about doing injections into eyeballs for macular degeneration, they could have 500. But what I share with my tight-knit group is we're the ones who are going to make that patient's life better. We're going to enhance the vision they have. As important as doing those injections are for maintaining vision, and believe me, it's a lot easier now for me than it was 10 or 20 years ago before we had injections to stop bleeding in the eyes from macular degeneration, because I have something to work with now. But we're still the ones, we the low vision practitioners are the ones that make life better, because we deal with the functional stuff. I often say, I was the first optometrist at Mayo Clinic. And I like to say that my colleagues, Mayo doctors don't like telling people that nothing else can be done. Low vision is the something else. So when they can't think of what else to do, they said, well, maybe you should see Siemsen over in low vision, see what they could do. And then the word got out, because what I told my colleagues is, I don't care if the patient is 20/20 and bitching about it, or they're no light perception, send them to me. It's my job to help them achieve their goals, if that's possible. So we pick up where they leave off, essentially. We talked about something else, I just talked about that. Now, let's talk a little bit about barriers. And there are barriers to providing rehabilitative low vision care. Need a GPS to find mom? So what are some of the barriers here to doing low vision? Well, you know, not everybody knows about us, knows what we do. I mean, we try at Mayo to say not just low vision, but low vision rehabilitation, because more people understand that concept. So, you know, there's a lot of misunderstanding about what we do. We don't just do magnifiers. We don't just do strong glasses. This is a rehabilitative process which encompasses a lot of different professions. There's lack of access to information. You know, I'm sure you guys know, because I was in preparation for this, I was on the internet and looking up different websites about nystagmus and practitioners and research studies, and you know, there's a lot of stuff out there, and it's really hard it's hard enough for professionals to sort through all this stuff and figure out what's accurate. You know, it's even more difficult for lay people. So access to this is improving because of the internet. And I certainly don't discount things that when my patients come in and say, I saw this on the internet, or some well-meaning family member pulled this off the internet, and I'm always happy to answer the questions. Most of the time it doesn't relate to anything that my patient has, but you know, we need to be respectful of that, because that's where information comes from. It can be a challenge at times to get reimbursement for vision rehabilitation services. Medicare, Medicaid, Medicare in particular specifically excludes optical services and optical devices. So that means we have to be creative when we're doing low vision, because we have to think about how are we going to structure the billing, the training for rehabilitation, and not just a general eye exam. And that also includes materials, because even a video magnifier, or CCTV, that's considered an optical device by Medicare. So we have to be a little creative, but you know, I don't know. They haven't pulled the plug on me yet, because they're not making enough money at Mayo, so I guess I'm doing okay. Lack of qualified providers, we talked a little bit about that before. You know, how do you know that the person you're dealing with actually knows what they're doing? It's a little bit of a challenge. One way that you can do it would be to go to the American Optometric Association website. It's AOA.org, and you could search for people who are members of the low vision section. Now, that doesn't mean that they've been certified, but it does mean that they have an interest, and you know, at least they get the mailings and they follow the stuff. The American Academy of Optometry, which is aaopt.org, also has a directory, and then you can find out who the diplomates in low vision are. So that's one way to figure this out. Now the last one, I added this, the last comment is in, and I almost took it out again, and I apologize. I should be reading each and every one of these points because I know that not everybody can see it, so my apologies. I'll be better.
The first organization was the American Optometric
Association, right.
Thank you.
So my last bullet point here is patients and families looking for a miracle cure. And I don't mean that in a derogatory fashion. I mean, everybody's looking for that magic bullet that's going to cure the disease that they have, whether it's cancer, macular degeneration. You know, everybody's, my mac degen patients are asking me, are they doing research on this? Yep, you bet, absolutely. Tons of it, billions of dollars worth of research. But there's nothing on the horizon that is going to fix it or to replace the vision that's been lost. And nystagmus, in many ways, is even more complicated because there's so many different etiologies for nystagmus, from foveal hypoplasia, optic nerve hypoplasia, different forms of albinism, different cranial anomalies. I mean, it goes on and on and on. So is there a lot of research going on? You bet. I've been doing this for over 40 years now, and I've seen some amazing and remarkable progress in the treatment of eye disease in that 40 years. And I am fairly confident that, you know, in the next 40 years, we're going to find out lots of answers to different types of eye disease, maybe even how to fix nystagmus. But in the meantime, our goal needs to be to, if I have a youngster coming in, I can look them and look mom and dad in the eye and say, look, I don't know what's going to happen next year, next week, 20 years from now. But right now, our goal is to get you an education, get your job, have a family, have just as good a life as everybody else has. That's our goal. So you can talk to me later about what's going on, you know, this surgery, this treatment, and I can kind of nibble around the edges. But that's not where I am. Where I'm at is taking what you have and getting you to do the things you want to be able to do. Does that all make sense? Okay. Now, who does all this stuff? Well, most low vision specialists are optometrists. There are a handful of ophthalmologists, it's just kind of the way it works out. Optometrists traditionally have done this because they are, you know, they're used to dealing with the optics and refraction, and so we know about magnifiers and glasses, and you know, we're a little bit more patient in terms of doing the refractions and that sort of thing. And most of the training programs, in fact, all the training programs in low vision, the formal training programs, are for optometry. I happen to have a hospital-based residency from Kansas City VA Medical Center, where they have the VICTORS program. The government has to have an acronym for everything. Vision Impairment Center to Optimize Remaining Sight. Yeah, VICTORS. But it's kind of funny, but you know, it was a multidisciplinary program which included optometry, ophthalmology, social work, blind rehab, brain rehab. I mean, we punched a lot of tickets in that particular program. So we have optometrists and ophthalmologists. I have utilized social work. I have a tremendous respect for social workers. The best compliment I can give them is that they have a good BS detector, because I have people who are in denial. Oh, I'm fine. I don't have any problem. You know, everything's just groovy. And you're thinking, you know, and you know that the spouse or the mom or the dad are over there. It's like, no. So you know, they have a good way of picking through all that. And also, they're a good liaison between our clinic and other services on the outside. So I really love having social workers around. Physical and occupational therapists. At Mayo, I have OTs. I don't know what happened here. I have OTs who are doing my training because that's the hand I'm dealt with, my experience. Prior to coming to Mayo was utilizing teachers of the blind and visually impaired, of whom we have a couple here in the background. because they're more trained in vision. OTs have less training in vision, but again, for my patient population, where I've got older adults who also have lots of physical challenges, the OTs do a fabulous job as well. So for every program structures this just a little bit differently. We also have early learning teachers, mobility specialists, rehab counselors. In addition to my traditional low vision patients, we're also developing a fairly robust brain injury section. Lots of discussion about concussions. You hear about that all the time, where we're seeing more and more of those people with their wacky vision problems. So lots of different people can be involved in this. And one of the fun things about being at the world famous Mayo Clinic, the WFMC, is that I get to interact with all these people, and I get calls and said, hey, in fact, I just got one last week from pediatric neurology. I've got this 16-year-old that was in a car crash. 16-year-old, brain tumor, doing radiation, living at Ronald McDonald House, and it kind of went down the symptoms. So any chance you could see them? Well, sure, send them my way. I'll see what I can figure out. That's my problem. I don't turn anybody away. I'm a real soft touch. Maybe that's why I'm here. No, I'm only kidding. So when we talk about a rehabilitation approach, so I want to differentiate between a rehabilitation approach and a medical approach. Many of you are used to going in and seeing your ophthalmologist or your optometrist. You get the whole, the chapter and verse about the medical conditions, but we're talking about rehabilitation here, and just a little terminology here. So a disorder would be the nystagmus. I mean, that's the medical cause of the problem. The impairment would be decreased visual acuity. Just don't see as big a letter. The disability comes when someone can't read a sign, and the actual handicap down the line is can't get a driver's license. So these are the different things. So we have to kind of be on the same page about how we describe this stuff. Normally I talk about visually impaired persons. So there is an impairment there. There's something we can measure that somebody can't see, can't do, and then we kind of work things out from there. Does that all make sense? So what's different about a low vision exam from just a general eye exam? Well, a lot of it is the same, except that I go into a lot more detail. My low vision exam form is 3 pages long if I were to actually print it out. Of course, it's all electronic now, but which helps because I type a lot better than I write, even before I had thumb surgery. But so I really want to know a lot about what's going on with the eyes. What's the cause of the problem? And not just got nystagmus. Okay, that's fine, but there's a lot of different reasons why people have nystagmus. And is this because of albinism or other conditions from that are congenital or acquired, or what's happening here? So I need to know what's going on with the eyes, because a lot of what I do, a lot of my treatment plans are based on what the etiology of the problem is. I've got some examples a little bit farther down the line in my presentation here. And I took out, except for the one on nystagmus, I took all the other ones out so as not to confuse things. But a lot of what I do could be used for anybody with a vision impairment, and some of them are very, very disease specific. So I really need to know what the problem is. Medical history. Anything else going on that we have to worry about? When I do a series of clinics every year for the Minnesota Department of Education. There are only a handful of us that do pediatric low vision in Minnesota. Actually, I started doing this when I was back in Illinois. We would do road trips with our resident, and we'd run around Illinois working with special ed associations, the State School for the Blind down in Jacksonville, and so we kind of went far afield. And when I got to Minnesota and the word got out that I was here, well, then the statewide coordinator, which was Gene Martin at the time, said, hey, we need somebody that can help us, provide services around the state. Minnesota's a big state. For those of you who aren't from Minnesota, we're only about a third of the way up Minnesota. We aren't anywhere near northern Minnesota where we are now. And I'm in Rochester, which is the far southeastern tip. I'm about equal distance from La Crosse, Wisconsin, and Decorah, Iowa. So, I actually live in Iowa. When I run around and work with their visually impaired kids all over the state, many of them are multi-handicapped. Some of them have physical challenges. Some of them also have cognitive disorders. So we've got to kind of work all around that and say how much of this is, and that's often one of the big questions when a child comes in with the parents and with the teacher. What can this kid see? What can we actually expect? And sometimes the only thing I can say is whether or not I think this child is going to be a print learner or not. Now the good news is with nystagmus, it's pretty rare that the vision is bad enough that if all we have to deal with is the nystagmus, they're going to be print learners. They're going to be faster print learners than Braille or just about anything else. But if there's something else going on besides the nystagmus, then we've got to sort all that stuff out so they know where to go. Now, I as a medical rehab professional, I don't tell the teachers it's time to teach the kid Braille. That's kind of outside of my responsibility. All I can say is, yeah, I think this kid is going to be able to read print or not, or they're never going to read print fast enough to be able to learn fast enough. So we kind of go from there. So we need to know a lot about this stuff. I also, when I get youngsters in who are either in school or approaching school age, I want to know what they're using now. What is their learning situation? Are they in a special classroom? Do they have an itinerant teacher who comes through? Do they have a full-time aide, a part-time para? What resources do they have available? Are there other children in that school district that are also visually impaired that they can draw on some experience? So there's a lot of, and even in big districts, sometimes they don't have a good, good support for vision impairments. Vision impairment is, and as well as hearing, are considered low incidence. In that, that's not, it's low compared to things like ADHD, dyslexia, reading disorders. That's high incidence stuff. What we're talking about here are the handful of kids, and I don't know about the number. Terry, I don't know if you know what the numbers are. The last time I asked Kristen Owen, who's the statewide coordinator for vision impairment here in Minnesota, how many kids there were in Minnesota. I think she told me there were about 1,500 kids in Minnesota that were receiving receiving some kind of services, vision impairment services in Minnesota. And what do we have? About 5 or 6 million people living in Minnesota. So you see, it's not a huge number, but it also means that if you only have, between myself and my colleagues who run around Minnesota doing these, we only do about 50 or 60 low vision exams a year, and we usually make a loop of the state every fourth year. So not every one of those 1,500 kids are getting low vision services just because we can't provide all the service. So there's a lot of variation. In Duluth, which is the 4th largest city in Minnesota, up in the corner, and oh, by the way, Duluth, if you look, it's right at the tip of Lake Superior, so if you look at the map, they're only about 2/3 of the way north of Minnesota. There's a lot of Minnesota yet after you get to Duluth. For the longest, for several years, they didn't even have a teacher of the blind or visually impaired working with their kids. And this is, the city and the surrounds is about 150,000. So you don't have good coverage all over everywhere. I want to know what kind of difficulties the person is having because of their vision. What are some of the things that you can't do now because of your eyes? And then we look at specific tasks and look at the function of those tasks and that sort of thing. Okay, now what does the exam look, the actual examination look like? Once I get done with the history, Then I'm looking at, I need to measure the distance visual acuity. And what distance visual acuity means is the ability to see a certain size letter at a certain distance. So if you see 20/20, you're seeing the numerator, the top number is the distance. That's the distance that the letter actually is. So 20 feet, and the numerator is the size of the letter. So somebody who sees 20/20, they're seeing a 20 size letter at 20 feet. I won't go into the optics of how that works, but that's what we're talking about. Someone that sees 20/40, they either have to have a letter 2 times bigger at 20 feet, or they have to get to 10 feet to see that same 20 size letter. Follow me so far? Someone who sees 2200, they're going to have to get to 5 feet, or I'm sorry, they're going to have to get 20, 10, 20, they're going to have to get to 2 feet to see that 20th letter. Or, you know, I got to make that letter 10 times bigger. All make sense? So that's really all we're talking about here. And visual acuity is a crummy predictor about, I've been listening to the news too much. It's a bad predictor of visual performance because it doesn't really tell us what the patient can do from a functional standpoint, all right? Which is why, you know, I'm sorry I didn't catch the driving presentation, but, you know, when I talk to people about driving, your ability to see a certain size letter on the chart has absolutely no bearing as to whether you're going to be a good driver or not. All the studies tell us that, because it's not, you don't need to be able to see a certain size letter, you know, 2040, 2060, 2100, yeah, all the states just pull that out of their hat. So I won't digress any farther with that. But we need to know, we need to have a starting point, and this is our measurement. I mean, everybody wants to have numbers. These are our numbers. So distance visual acuity. Near visual acuity, same sort of thing, although we measure it differently. We don't generally use 2050, 2100, because it all depends on how far away that target is from the patient. I've got an example coming up here, so you'll be able to see how we manipulate that. But I need to know where you're at. How big is the print you can see? What's your goal? Then I know how big I've got to make things to get you to that goal. Glasses. What do they bring in? We always tell people, bring in every pair of glasses that you have, every magnifier, anything that you use or your child uses to be able to see. That's what I want to see. If you're using a tablet or a laptop or a Chromebook, bring it in. I want to see what you're doing with it. I wish they always brought stuff in, but they don't. But anyway, I need to know what they're using now. Many times, they have the right materials, but they're just using it improperly. So if that's the case, great. Send them off for training. Life's good. Now, refraction. Refraction refers to measuring the power that we're going to put into a pair of glasses. So the first thing we're going to do is recheck the refraction, because I'm going to put the sharpest image possible on the retina. So the distance refraction, which is better, 1 or 2, and come on, everybody's done that. I want the sharpest image on the back of the eye. Now, for people who have really poor vision, it's hard for them to tell. So I have hand instruments that I can get a good objective finding that I don't need much response from them. From a nonverbal patient, using an autorefractor that gives me that raw data to start with is usually a good thing. But when people say, can you give me a stronger pair of glasses? Well, I can, but the first stage is to do the refraction to get the sharpest image possible on the back of the eye. Got that part? And then everything else kind of goes from it. Because if I don't have the right refraction, if it's way off, well then nothing else is going to line up either. And I get the tip-off often for me is if I get an older person, let's say, who should not be able to see up close because of, you know, they've got old eyes. Presbyopia is literally old eyes in Latin. If they're holding things up here and seeing it, they can't be farsighted. They have to be nearsighted. So just observing the patient, I can get a pretty good idea where they're at to start with. So we got to do a good refraction. And I don't do mine in the back of the phoropter with the dials, I use loose lenses. Okay, I better get moving here. I'm going to calculate the reading at, and then we're going to get into low vision devices. And what does that really mean? Let's go, before I get into devices, let me just talk a little bit about the questions that I ask. Why is this patient here? Why are you here today? I want to see better. Well, sure, I'd like to see better too. You know, I'm an 8 diopter myope. But you know, what do you want to achieve in this when we get done here? What do they want to do that they can't do now because of their eyes? And be specific. I want to be able to read. I want to be able to, you know, cook, stay dependent, stay in my home, whatever. And sometimes people just can't focus in. So I'll have to say, okay, you've given me a whole laundry list here. If there was one thing that I could do for you today, what would that be? And that's what I'm going to focus in, because I really like to give people some success right off the bat. If there's one thing that I could do, what would you want that to be? And we're going to kind of get beyond some of this. So what do we really do in low vision? Most of the time, I'm making it bigger, because remember, if somebody's got 2100 vision, I've got to make it 5 times bigger. So how am I going to do that? We monkey around with illumination and contrast, so we can change I can use external lighting to make the print pop off the page. We can use a tablet to do reverse contrast, white on black, do things on the laptop, that sort of thing. Training is essential, because even if I give somebody the proper device, if they're using it improperly, it's not going to work. And we also have to deal with psychosocial issues. I mean, people come in with lots of baggage, and I don't have any social work training, but you know, people are in my office and they're hurting, and you know, and I can see, you know, mom or dad or spouse over in the corner, and they're kind of getting, you know, they're a little weepy. You know, how are you doing? You know, so that gives me a little bit of a, you know, okay, we're going to have to get somebody else on the case here. Different devices that we use. We use, when I say a high plus add, what that means is strong reading glasses, strong bifocal power. That translates into, if I increase the power of the bifocal or the reading glasses, it means you have to hold things closer. So every time I make it stronger, you got to hold it closer. And what that does is, if you hold things 2 times closer, makes it 2 times bigger. This is not rocket science. But we have to come up with a prescription that focuses at that distance. We use magnifiers, we use telescopes, monoculars, we use spectacle telescopes like our friend here has with his Designs for Vision scope. We have glare control devices, which are you know, sunglasses, filters, wraparound, side shields, a bunch of different things. Tinted contact lenses. Doing a few more of those. And more today we're using electronic devices to help fill in the gaps, because even children who are not visually impaired are using iPads, tablets, Chromebooks for their schoolwork, and we've got to be able to cope with all that stuff. All right, we're kind of running short on time here. I'm going to pass by my examples, and we're going to get to some questions. Okay, I'm going to stop at this page just for a minute here. When we're trying to figure out how big the print needs to be, this is a little conversion chart. Newspaper print is 1.0 m in size. It's about 1.5 millimeters high. A lowercase o or e in a newspaper is about 1.5 millimeters high. Large print is about 2 times bigger than that. So it's not a lot, but you know, it helps a little bit. So let's say somebody can read. So if you're trying to figure out how much magnification your child needs or you need, if you figure out, you know, take a headline in the newspaper or some other big print and said, yeah, I can see that. Take out a ruler with millimeters, measure it, and divide it by 1.5. And that'll tell you how many times you have to enlarge newspaper-sized print so you can read it. Does that make sense? So that's a really simple conversion that anyone can use and you can measure. So we use that, once I figure out what they can see, then I think, okay, I've got to make it X so much bigger, and then I can decide on glasses or magnifiers or tablet or whatever. All right, let's get beyond this. A couple of examples, and maybe once I've got this thing down pat, so maybe I can give the the final version of the PowerPoint to you, and you can share that however you do. So you'll have copies of it. You can kind of read through all this. It's pretty self-explanatory. Okay, so I think I probably talked enough here. Let's take some questions. Jim's got his cards, or my cards, and he can play. I can play Karnak. He's my Ed McMahon.
I was just.
Isn't he old enough to know who Karnak is?
I was just gonna try to find some newer reference of that. Yes, thank you. So look, thank you for the questions. We've got a few related to low vision specialists in general.
Okay.
So I thought those would be good to start off with. Then we have a couple more specifically related to nystagmus that I think we'll want to hit too.
Okay, good.
So the ones related to low vision specialists are about, do we need a special consult or referral? Let me just read them and you can choose through. Do we need a special consult or referral to see you or another low vision specialist?
Yeah, the answer is, do you need a special consult to see me? No, although sometimes you'll get my the wrong appointment coordinator at the WFMC, and oh no, he's got to go. But technically, no.
Okay, but keep trying because he's hard to reach. I almost had to tell them that I was calling about his golf times for them to let me speak to him. So
I wish I had time to play golf.
So then there's a question about TVI. Does TVI provide the same services as a low vision specialist? That's a title of visually impaired? Is that what
Teacher of the visually impaired.
Yeah.
Teacher of the blind and visually impaired. No, it's different. I mean, they're dealing with education. And what when I'm working with visually impaired kids, part of the reason why we do our outreach clinics in Minnesota is because our goal is to get the student, the teacher, the parent, and the doctor all together at the same time, which doesn't happen if the parents are bringing the kid in. A lot of times the teacher's out of the loop, and that's a problem. So it works a lot better having the teacher there with us while we're all working together, because then we can have this dialogue about, here's the devices, here's how they're going to use them, and I know that, all the teachers have their pile of magnifiers and monoculars, and that's fine. I don't get hung up on that. But, it helps them a lot if they know how big things need to be, how much the child sees, and, what's the power, how they should be using it, what circumstances, that sort of thing.
And so moving on to a couple of questions about nystagmus in particular. I thought this one was very interesting. Because at this conference there have been a lot of doctors sharing some research on nystagmus. So there are one related to low vision and another one in general. So if the diagnosis for a patient is nystagmus, and that's the only diagnosis, at what age is it recommended to start seeing a low vision specialist, and how often after the initial consult should they come back?
I don't think it hurts whenever the child starts school, and I think that's that can include preschool as well. The other reason why I like to see small children is just so that the parents understand what to expect and what questions to ask the school.
Right.
When I was, Jim signed me up on the Ann Facebook page, and just reading some of the comments on there, parents of children that have been newly diagnosed, what do I expect? There's being able to sit down with the parents and explain what's going on, what the child sees, what they can expect. Here are the questions you ask the school. Now, in our area, I've been around for a while, and a lot of the school districts and special ed organizations know me, and we've got a good dialogue going, and they know what to do with the kids. That's not the case everywhere. And you may be in a district where they don't know what to do with a visually impaired youngster, and so I need to kind of lay out what what questions to ask.
How to advocate.
Right. How to advocate for your child. So, and what to expect. This is, you're going to have a great kid. This is not the end of the world. It's not, lots of people have lots of different problems, and this one happens to be relatively manageable. So let's go on from there. Let's look at the positive side. Some of you who know me know that my wife is a pastor. And we were having a conversation on the way in this morning, and we were talking about taking a look at the blessings that we have instead of just looking at the bad cards that we got dealt. So take it from that perspective, and I like to look at that positive side. Is this going to be perfect? Is it going to be as easy as many of you might have teenagers or adolescents that have drug problems and have all sorts of other issues that are going to be a lot more difficult to handle than nystagmus is. And I don't want to minimize the nystagmus part, because I know that's why you're here. But this is manageable. But the sooner we talk to parents and say, hey, this is how it goes. People leave my office and say, oh wow, okay, now I get it. This is going to be okay. That's what I want. It's going to be okay.
And we have a lot of, ideally and hopefully a lot of people leave here feeling similar.
Yeah, I hope that you leave all of these sessions with the feeling like, yeah, I learned something here. Life's going to be better. That's the point.
Now, we do have a lot of sessions talking about kinds of nystagmus, eye movement recordings. So a question, and actually this is a great question, this is on my mind as well. What is the benefit, or is there a benefit from your point of view in identifying an underlying condition causing the nystagmus when they go to see you?
I don't know that there's a tremendous benefit from my standpoint, other than I think we probably need to know if this is going to be a progressive condition or it's going to be stable. If it's stable, most vision loss related to nystagmus is stable, so it's not going to get any worse. Okay. So when I'm writing out those forms for driving, it's like, this is stable. Don't bring this person. Don't send this person back to me every year. Molly's laughing here. Don't send this person back to me every year, because it ain't going to change. It's going to be the same for the next millennium.
So on to a couple other questions. I think some of these we've hit, but there was a question in particular around something that you might see in particular with people with nystagmus, and that is around eye strain. Mm-hmm. and muscle and eye soreness sometimes that comes when people have nystagmus.
Good question. And I kind of glossed over, I ran past it here in my examples. How many people here with nystagmus? Okay, we got a bunch of them. What do you do when you want to see some small print? You hold it closer, right? And when you do that, so imagine a youngster who holds things close, and they hold it close because it makes it bigger. Remember what I said? Twice as close, twice as big. If you go from 10 inches to 2 inches, we just made it 5 times bigger. But you also have to accommodate 5 times. And you have to converge even more than that. The eyes have to turn in to aim at that spot. And youngsters can do that. Young people can do that. When you get old and gray like me, you can't do that. But if you're less than 40, yeah, you can accommodate, but it takes a lot of work. That's really stressful. So almost one of the first things I do is figure out where are they holding the material, and then I either give them reading glasses or a bifocal for that distance or something close to it, so they don't have to do all of the accommodation. And if it's too close that the eyes can't converge and get one image, then we only do one eye, we block off one eye, and that often will reduce the fatigue significantly. Now, today again, remember what I said about tablets and iPads? Well, if you make the print a little bigger, maybe they don't have to hold things closer. But what I tell parents is, look, if I give somebody bifocals or reading glasses, they'll still hold it close, but they're not going to be as straight. All right? Well, they hold it so close. Yeah, they have to, because that's what makes it bigger. So I hope that answers the question. So that's like one of the first things we do to reduce strain.
and questions about oscillopsia affecting nystagmus, and how can low vision rehabilitation help a child who may have nystagmus and oscillopsia?
I can't really reduce, if you Google nystagmus and contact lenses, you'll probably see claims made to reduce eye movements with contact lenses. I don't know that that really exists. I mean, we used to think that putting a rigid contact lens on someone and there was like a feedback loop between the eye movements, and they'd feel the lens on their lids, and it would somehow magically reduce the movement. I don't really think that happens. I think what happens is with certain refractive conditions, patients will see better with a contact lens, and because we got a sharper image on the back of the eye, that can reduce the movement. But I can't really say that much of anything else I do makes that difference. One thing though, sometimes I have to put, if their null point is up, down, one of the examples I give is a girl from back in Chicago whose null point was superior gaze. So we put her bifocals on top so she could go like this and read. It would slow down her eyes and she wouldn't have to accommodate so much. So we do stuff like that.
And I thought this was a good question. Why does the title low vision also cause an item to be priced higher? Similar items not labeled as low vision can be gotten at a much lower price.
That's a good question. What magnifiers, for example, people will come in with magnifiers that they got at some big box store or they got online, and the optics are so bad that they can't, they're kind of unusable. And you get a big magnifier. I want a magnifier that covers the whole page. Yeah, well, it doesn't work like that. I can't break the laws of physical optics. So one of the fun facts about optics is that the stronger the lens, the smaller it gets, the smaller around it gets. And the best quality lenses are, most of them come from Germany, some of them from Japan, and we're cognizant of that. I mean, I've got a couple of different lines of magnifiers, and some of them are really high end, and the optics are fabulous. Some patients can tell the difference, and others can't. So, I mean, I pay attention to the cost because most insurance doesn't pay for magnifiers and optical devices. So I try and pay attention to that sort of thing.
And that takes care of most of the cards I had, unless you wrote something that I didn't mention. We have about 5 or 7 minutes left. Additional questions you guys want to ask? I see Molly in the front.
Okay, so my question is, I've heard twice now from parents at the conference that they didn't even know that low vision teachers were a thing or an option. Do you have some recommendations of where they could go online to just look that up initially in their area? Good question, Terry. Did you hear the question? How do if they don't know that there's a when I ask them do you have a teacher of the blind or visually impaired, like they look at me like I'm from Mars, like I don't even know what that is. Yeah. Terry's a TBVI.
Hi, I am a TBVI here in Minnesota. I would suggest that you go to your whatever state it is, the Department of Education, and look under special ed for either low vision or visually impaired or one of those phrases to look and see what the incidents, how many teachers there are, where they're located, or who to contact to find that out. There is a shortage, so there are many districts that unfortunately have to go without and try to find someone. So if you know someone who's going to college and wants a new career, have them join in.
While Jim's walking in the back, let me say one more thing too. If any of you have youngsters students who are going off to college, when you're doing your college visits, one of the stops should be the Office for Students with Special Needs and find out what they do for students with vision impairments. An important stop. Okay.
I just wanted to say that in our state, it was under Services for the Blind, and that totally confused me because I was thinking low vision, and it was actually like Services for the Blind was where I needed to go to get the low vision services. Yeah. I mean, you could always call your state Services for the Blind, and they would probably tell you where to go. But most states, it's segregated. The adult program won't touch a youngster in school. Here in Minnesota, they overlap from about sophomore, junior year
in high school. They overlap so that by the time the student gets done with school, they're on their way to trade or whatever they're going to do.
Great.
I'm a special education coordinator, and under the Individuals with Disabilities Education Act, even if your district does not have one, they are legally required to provide you one. So whether they have to contract with another district to get somebody for you, but you are, they're legally required to do that whether they have somebody or not, and it's at no cost to you.
Yeah.
I just want to piggyback. I'm a special ed teacher as well. I'm not a coordinator, but if you're in that IEP meeting and they're not talking about this, then you need to make sure that you bring it up, because like she said, it is required by law that you get those services, or your child gets those services, and sometimes they won't bring that up because it's more money out of their pocket, and if you don't know, then you can't advocate for your child. So make sure that you bring that up, because they might just pass over it since it's much harder for them to find somebody.
Okay, we have a question right at the front here too, Jim.
Thanks.
She's been waving at me.
So you and your team are up here in Minnesota, but do you have any way that someone in another state could find out if there's low vision specialists, or where to find them in their state?
Well, so the question is, how do you find out who does low vision, who provides low vision services in your state? One way would be to contact your state agency that works with blind and visually impaired. Here in Minnesota, it's State Services for the Blind. In Wisconsin, it's the Office for the Blind and Visually Impaired. They typically will have a list of practitioners that they work with, either they refer to or that they, sometime back in Illinois, we were registered with them. So they've generally got a list. Otherwise, it's the American Optometric Association or the American Academy of Optometry, because then yeah, right. So those you can look on those, find a practitioner, and there's usually a search option to find out who the practitioners are. And sometimes I'll have a patient from out of state, or somebody will have a patient from out of state, and I'll get a call. They can't stay and see you. Who do I send them to when they go back to, Nebraska? All right. Well, then I got to go searching in Nebraska. Do I know anybody? No. All right. Then I go to my directory. Do I know anybody? No, I don't know anybody there either. So then I have to work backwards. So, yeah, Jim, we get.
I got one here. Basically, I've been using these same glasses since about 1983, and I'm curious, has there been any changes?
Good question. Good question.
Optics?
Okay, you want to hold those up? So he's got a Designs for Vision spectacle-mounted telescope. This is a spiral Galilean telescope. You really know all this. Actually, no, that's a Keplerian telescope. Anyway, so these are like binoculars, telescopes that mount into a pair of glasses. Those things have been around since, well, long before I've been, like I said, I've been doing this for 40 years. I won't tell you exactly how long, but they've been around for a long time, and they're good because they, optically they work really well. They're precise. They're not outrageously expensive. We're not talking about $10,000 here. Usually I can supply something like this for a patient for well less than $2,000. I know that's a lot of money. It really is. But in the big scheme of things, if you've got a task that you need to do, it's a way to do it. And there are other companies that make spectacle-mounted telescopes. So right now, the optical distance magnification devices still are the go-to device. If you've heard about eSight, if you haven't, Google it. It's an electronic device. Many of you have heard about the Geordie. That's the old device. Well, the Geordies were basically what you have is you got a pair of goggles, and you got a TV camera, and it goes into that pair of goggles. Well, the problem is that the resolution isn't that good. It blocks your peripheral vision. They're big, they're heavy, they're clunky, and they're very expensive. Enhanced Vision, who makes desktop video magnifiers, they make some handheld portable video magnifiers. They're coming out with a new version of the Geordie that will be smaller. They're still clunky. You know, think about those, the 3D goggles that you put your cell phone in. That's about the size of these things. So there are going to be some new devices coming out, I think in the not too distant future, that will be really cool, will be priced that normal people can afford it. But I think there's always going to be a place for the optical devices. They're good because they work. They work. They're portable. Yeah, they are heavy. Yeah. There's no. I know. No way around it. And the reason that they have to be big like that is that in order to get that kind of magnification, you have to have two lenses separated by a certain distance. So it's got to be, you got to have strong lenses, and they got to be separated by. So that's why it's got a long tube on that thing. That's. Remember the laws of physical optics? Okay, we should probably stop because we're going to be encroaching on the next one. But I'll hang around if anybody has questions.
Thank you so much.